So Aimee and Race, if you want to start just kind of talking about who we are and why everybody's here today, and then dive into the content in just a few moments. Good
Yeah,
morning to Race's daughter, Amelia.
I am so excited to be here with my amazing friend and colleague, Rais Vohra, because I remember way back in the beginning days when we were both trying to get programs going, and really kind of looking around, scrounging to kind of build a program. Going onto Google to try and find any place where we could kind of build a program, and find partners and places and resources for our patients. And so just really excited to be talking to everyone here who is in kind of that same space. Either you have a program and you can reflect back and share all those amazing experiences that you had in building your program, or even if you're at the very beginning, like we were thinking, how can I get this started and build my program? So just as background, I'm Aimee Moulin. I'm an emergency physician at UC Davis, and I am now actually boarded with addiction medicine and emergency medicine, which is new. So just wanted to share that with everyone. And then I'll turn it over to Race to introduce yourself, and then we'll
Hi,
dive in.
thank you so much. I'm so excited to be doing this, and just to reciprocate. I mean, Aimee, she's been kind of like a big sister and a mentor, and I really just appreciate so many things that have happened since our first meeting, because she's the one that really got me involved and really, opened my eyes to the great work that was being done in this space. My formal background is I'm an emergency physician as well, and I'm also a toxicologist. And so I have this other perspective where, I've been watching really just the gloom and doom related to opioid epidemic, through the lens of the Poison Control Center, where I'm the medical director, and just the toxicology side. But then really the things that we're going to talk about today is far removed from gloom and doom. This is really just the sunshine and rainbows that I think everyone is looking for whenever we talk about opioids. And so we're just happy to share our stories, and you'll see a lot of hopefully commonalities in the narratives that we're going to present, and hopefully we'll have lots of time to actually open up discussions related to specific questions that you might have. So while I wrestle my 4-year-old, I think, Aimee, if you want to take over and start, you have the first few slides, but then we'll sort of switch back and forth. And hopefully, as long as I stay alive this hour, then I'll be able to jump in with my comments as well.
All right, thank you, Race.
And this is Amelia Jane. Say hi.
Here's all of an adventure in multitasking. So I think
that's right.
We all share our amazing coworkers at home. So this is just a little bit California Bridge. So this is a program of the Public Health Institute. And really what we have tried to do is promote evidence-based treatment for substance use disorder in emergency departments. And it says California Bridge, but we know that substance use disorder does not stop at our California border. So I'm hoping that there are some of you out there who are outside of our state who are also going to engage in this work, because we know that this is a shared experience, and hopefully we can all learn and grow from each other. And we can go on to the next slide. Okay, so this is a graph that recently came out that shows overdose deaths in the United States as well as in our state. And it goes through March 2020, which is really kind of where we start to see the beginning of the pandemic. And what we can see both in the state of California and across the country is this line is not going in the right direction. And I think if we pulled this out to current day, I think we all recognize that we've got a lot of work to do, and that this pandemic really kind of dug us into a deeper hole in terms of mental health, social isolation, economic insecurity. We know that these are big drivers, particularly of substance use disorders and, feelings of depression and isolation. The other thing that when I'm struck as I look at these graphs, and we see these numbers, sometimes it's sort of overwhelming. And it takes a moment for us to recognize that these are people, These are lives. These are our family members. I recently, and I'm just going to digress for a minute, but I gave a talk, and one of the questions I got was from someone who said their son recently overdosed and died. And her question was, did he suffer? And that really struck with me. And that just single question really drove me to think about this graph differently. And each one of these is a life lost, but also someone that is missing, a loved one, a family member. And so I think when we look at this graph, we have to think not only in terms of, hey, we're going in the wrong direction, but these are people that we've lost. And so this is something that I just wanted to take a moment to kind of reflect on, of why we're here and why the work that you all do is so crucial and vital, because I think together we can really turn this around and do what we all came to do, which is save lives and make those stories ones of success. Next slide. And so I think a key piece of what is also behind the tragedy of those numbers is opioid use disorder. We're going to get to this. Really, we have great treatment for opioid use disorder, really fantastic treatment that works. And it is the system that is designed to fail. The way that we have set up our current system for people to access treatment really is punishingly wrong and tragic. That we have long waits, we have complex assessments, we have referrals to specialty care, insurance authorization, rigid treatment contracts, and really stigmatized, judgmental treatment. When really what we need to do is to get medication into people and to really do everything we can to do to drive people into treatment, because it is remarkably effective. Next slide. So here's what we're going to talk about today. We are not going to talk about doom and gloom. We're going to talk about how we're all going to pull together and fix this problem. And I know that there are some of you out there who are thinking, this is kind of overwhelming because I feel like I have to build a system from scratch. And we've all been there, and we've all been in that space. And so what I'm hoping we can do is kind of share our stories of successes and our shared challenges so that we can all move forward together, because we can really fix this problem. So we're going to talk about the California Bridge model, how you can build your hospital program, how you can look at your public health infrastructure in a whole new light, and then think about sustainability and beyond. I know that's a lot, but we're going to do it together. Next slide. So this is really kind of the pillars of our California Bridge model. We're trying to take that backwards, really difficult to navigate system and flip it around. We're transforming the system of care for people with use disorders so that it works for them. And it is built on this concept of rapid evidence-based treatment. So someone who is in withdrawal, they need to be treated right away. I call it door to buprenorphine, and it really needs to be that. We need to remove all barriers between a person who is suffering and their stabilizing treatment. Connection to ongoing care. And when we say a warm handoff, I don't mean just the usual, here's a referral. We believe that we should handhold that person, break down every barrier from pharmacy to transportation, so that we can make that transition from use into treatment as successful as possible. And the third piece is really what is the hardest, but I think really the most important, is the culture of respect, and that people need to be treated with dignity, and to really remove a lot of the stigma around use disorders. And so this is really our model, is to take people and to provide treatment, break down those barriers, and to do it in a way that respects their humanity. Next slide. And I'm going to turn it over to you, Rais, to talk about really how we can put this model into use.
Thank you. Yeah. So just setting the framework for the next part of this talk, we really just want to really share what has worked, I think, for both of us as just kind of a larger vision. Hopefully, many of you that are on this call are familiar with the basics, the pillars, as it were, of MAT, of the Bridge Network, and the work that we do. What we want to focus on now is, how do you kind of build what I'm calling a virtuous cycle, which is where you get enough momentum, enough stakeholders that are working with you to where you can really sustain the work that you're doing and expand it in a way that makes sense for your organization and for your community. And you're going to be able to reach just a lot more people that way. So it won't be isolating. It won't feel like you're perhaps the only person or fighting such an uphill battle. There's a lot of little secret, tricks and I think tips that we had to just learn for ourselves. That I wish somebody had sat me down and taught me on the first day of my Bridge program. And so that's kind of where we want to go with just sharing some of the best practices that hopefully you can take away after this talk. The specific questions that we tried to answer for this section was how do we change practice? How do we establish rapid treatment of opioid use disorder? And how can we meet a higher standard of care within our hospitals, within our communities? How do we actually, make sure that this model really fits with that standard of care? So the next slide, I think, helps to put it into perspective for the emergency department. Is, many of you are coming from emergency medicine or have that as your background. You're going to be spending a lot of time in the emergency department because that's where, obviously that's where ED/MAT is going to get done. And I think that this is just a really key study. It came out just a couple of years ago. It actually came out after the Bridge program started. And this really, I think, highlights the emergency part of emergency department MAT. This was a study where it was done in Boston. They actually followed patients who overdosed and then survived. And usually overdosing and surviving is a victory, right? I mean, that's what we high five each other, we pat each other on the back. That this is what toxicologists live to do day in, day out, is saving people that overdose. So that should be the happy end to a story that emergency medicine is doing. And that has been the last chapter of that story for a long time. But what these people did is they followed these people that survived from non-fatal overdoses. And then they basically said, what happens to these people? And then that story becomes a little bit sadder, just like Amelia's having a sad time here, I'm sorry. And that story is that these people don't actually do that well if they're not plugged into MAT. And that basically is what's shown in this graph. About a fifth of the people that went on to die did so in the first month. And about a fifth of those people actually died in the first 2 days. That is stunning. This just like floored me whenever I saw this study. I don't think that is unique to Boston. I think this is happening all over the US and it's happening in California. And that's important to know, is that just because somebody survives an overdose, we're not done. We've got to plug them in so it doesn't happen again. Because if we don't, then they're going to go back out and just get trapped in the same cycle that trapped them before. And it's not going to end well for them. So that's kind of why this is such an important study to know about, is because it basically proved what I think a lot of us suspected, which is that you can't just stop once the resuscitation is over. You have to keep going and really close the loop with these patients and make sure that they have a context of care that's really going to serve all of their needs. Next slide. So just following that right up, what you also want to, I think, focus on doing, and this should be, I think, part of your overall vision, is to make this as easy as possible for not only the patients, but also for all of the staff that you work with and all of the other doctors that you work with. Make this easy, make it a really simple, almost barrier-free access, like Aimee said, the door to buprenorphine for both the patient and the providers treating them should be as ubiquitous as possible. And that means, putting up signs everywhere. The signs obviously signal to patients that we're there to help, but they also signal to our own staff. And I think that that's something that I didn't appreciate until we started doing this in our own emergency department here in Fresno, is we have signs, we have buttons that we're handing out to all of our administrative staff and clinical staff. And we're really trying to make this a place that is very welcoming and kind of embraces the problems that people come with so that they don't feel stigmatized about talking about them. Next slide, please.
Okay,
so go ahead.
So we believe in making things easy. to be successful. And so this is our website, and we are here for you. We have put together this beautiful website, and I am actually in awe of our website folks who have done such an amazing job. So Sky Christensen, shout out to you. So this is our website. We have pulled together all of the resources that you could possibly need and put them all on one spot. And so essentially you can go to our website. I even posted a YouTube link where we go through how to use the website. So I just want to let you know that this is out there. This is live. We have all of our algorithms and where you can go for more help right there on the website. YouTube links, videos, toolkits, anything that you might need to kind of build your program and get it going. And I actually frequently refer to our website because I'll think, what did we say about alcohol use disorder? And I will go and look up the algorithms. And we have done our very best to make the algorithms really easy, pull out anything that we think is unnecessary to make it as easy as possible. Next slide. And super exciting, we have a mobile version, so you can just use your phone, bookmark our site, and pull up resources. So if you're on shift and anyone has any questions about how much to give or what a medication profile they should give for this specific disease process, we have that there for you too. So just wanted to let you know, as part of this, we're trying to make it easy for everyone as well. So this is out there. Please use the website, take a look at it. It's really beautiful. So next slide. Grace, I'll turn this one back over to you.
Okay, great. Thank you. Yeah, this is so this is a fun slide for me because this represents some of the best conversations and some of the best experiences that I had related to my own bridge program. And I think this is really an untapped area where you can make some rapid progress. So once you've kind of, laid the groundwork in the emergency department, you'll rapidly realize that you need other departments to support you in this work, and also that they need you. And so building your network outside of the emergency department, you'll just be able to find so many stakeholders. People will just come out of the woodwork and say, I'm interested in this, please teach me, please let me know how I can help you. Do you have any resources that we could distribute to our department? And so I just started going around to like all of the monthly departmental meetings, and I kind of had my 20-minute spiel that just talked about what is ED-MAT, what is buprenorphine, how does this work, what is a substance use navigator, and how can I get a hold of that person? And basically just the very basic things that you could do off the top of your head, just to have that kind of pitch, as it were, and then just go around to every department that you can and really just try to talk them up. So internal medicine, they're always kind of overworked, and so they always appreciate any help to help streamline their care because their patients usually have very complicated histories and workups. And so if you could just take the substance use disorder piece of that and just say, hey, this is a great algorithm, it's evidence-based, it'll make your life a lot easier, and the patients are really happy, here you go, here's a one-pager. They will just, thank you so much. And so my internal medicine colleagues call me all the time about any troubleshooting that we can do together about these patients. But, after a while, they just kind of get the hang of it, and they just start doing the ED, MAT, even when the patient's gone upstairs. ICU, in the same way, they're very supportive. They love the pharmacology of MAT, and so they really will ask you about receptors and half-lives and things like that. And then obviously they get the sickest of the sick overdoses. They get the teenagers. They get the endocarditis patients that have end-stage problems from IV drug use, et cetera. So I think they get it. They're very passionate about going upstream, even though they're the most downstream doctors in many cases of where these complications lead. Anesthesia and surgery, again, there's a huge push, it's probably a decade old now, about looking for alternatives to opioids, and yet it's still not formally taught in a lot of different training programs. So whenever people from addiction medicine or from the Bridge Network come along, they find a ready audience among anesthesiologists and surgeons that are like, oh, wow, there's all these alternatives to opioids that will actually prevent opioid use disorder from manifesting in my patients. Of course, I want to hear more. Same thing with pharmacy. They will definitely be very supportive, but I found that they're also very tough critics. So whenever we try to get buprenorphine on our formulary, and whenever we try to explore other ways of doing, for example, long-acting medications, et cetera, or even just alternatives to opioids, pharmacists actually ask the hard questions that need to be asked. And so I really appreciate them as allies who I know will have my back once we kind of have that connection and trust. Next slide. Just a few more departments. Again, these conversations get easier and easier, and you'll find your network builds very quickly once you start to just kind of talk up the value of knowing about MAT and the value of helping patients, whichever department they land in. So one good example is OB-GYN. So OB-GYN, like I'm certainly not an expert, and so I really leave all of those decisions to my colleagues related to pregnant women. But pregnant women with SUD are definitely ready to make a change, and they're definitely kind of like that scarier, higher stakes patient for everybody involved. So they really do need a multidisciplinary approach. And OB-GYN is always very supportive of hearing about insights and perspectives from addiction experts, and really just, again, just like internal medicine, they want to make their own lives easier. And so they were more than happy to help us with getting our bridge protocol started in their department. I threw in just some other miscellaneous departments here, like the sim lab and social work. It just depends on what your organization does. You may have a sim lab, you may not. You may work at an academic center, you may not. Same thing with social work and case management. I know that they're set up differently at different places, but just keep in mind that there's a lot of different options there. I think you can always have these conversations. If you have a sim lab, then certainly reach out to them and say, hey, I have some great ideas for, we could do patients with opioid withdrawal, basically. And then you already have the ready-made bridge algorithm, which serves as a script, as it were, for running people through the sim lab. And then that's a really safe way to get a lot of learners to know about what opioid use disorder presents like and how you can treat it effectively. With social work and case management, they're going to be BFFs with you as a clinician and with you as a substance use navigator, because they're asked to do this work already. I mean, they've been doing it for many decades. And so any help that they can get, especially with someone that has formal training and skills through the Bridge Network, or has the X waiver, if you're a clinician, that's only going to help them take better care of those patients and address all of their different social and case management needs. So they're going to be more than welcome. I mean, you're going to be more than welcome to come talk to them and really present to them and really get them on your side about, hey, call me about these patients whenever you hear about them, because we can work together to really intervene earlier rather than later and create a disposition and a discharge plan that works for everybody. So they're very appreciative of those kinds of conversations. Your hospital media team, believe it or not, they will want to document your wins and your victories. This is obviously quite a sensitive topic, but it's also a topic that a lot of communities care about outside of medicine. And so whenever you talk to your hospital media team, just the fact that you're involved with the Bridge Network, just the fact that you're a BHPP site and doing work in this space really will win you a lot of points and win your hospital a lot of points with the community. So take advantage of that and really leverage that to really share about some of the success stories that you've had, because that will actually, again, accelerate your own success. And people will come out of the woodwork once they know that you're doing this work, and people from the community will come out to you and say, hey, I saw this on social media, or I saw this on the local news, and here's how I can help, or here's how I think you can expand your work. And then last but not least, again, it goes without saying, make sure the C-suite knows about the work that you're doing and knows about the value that you bring, just in terms of preventing complications, saving lives. And we'll talk about this a little bit later, but now that there's a billing code for EDMAT, you can actually help create a funding stream that will hopefully help sustain your work as well. So obviously, it goes without saying, having friends in the C-suite obviously pays a lot of dividends. So keep that in mind too. Next slide. In terms of building outpatient partnerships, again, it really depends on what your community offers and the kinds of conversations that you're able to facilitate. You could do just this as your full-time job and nothing else and still feel like you're not doing enough. So it is easy to get overwhelmed, but you know, if you plan strategically, you can start to have these same conversations outside of the hospital. And I think that that really helped us here in Fresno really build just a lot of outpatient connections, which now are paying off just because we can rely on a lot of outpatient partners to help our patients depending on what's going on with them. And that, you know, first and foremost includes knowing your primary care landscape, meaning, you know, obviously your family practice doctors, your internal medicine doctors that are doing primary care, also your FQHCs and your tribal clinics. So don't forget that the primary care landscape can actually be quite complicated, but they do serve just a large number of people with different needs. And so just getting to know them, and again, just sharing what you do out of the emergency department and what they could help do. A lot of primary care doctors are actually very interested in getting X-waiver at this point. And so that's great. You can actually help facilitate them by putting on X-waiver courses or pointing them to ways that they can get X-waiver courses accomplished online. And all of that will help just strengthen your community safety net, as it were, for substance use disorder patients. Connecting with the justice system and drug courts. So this is something that I would have never dreamed of, but one day out of the blue, my substance use navigator, Chaya, who's actually on this call as well, and I were just kind of invited and summoned by the one judge in Fresno County that does drug court. And she called us into her chambers, and I had no idea what to expect. I thought she was gonna, you know, sentence me to something, because I was like, am I in trouble? And so we just went there and we brought our pamphlets with us very apologetically. And we said, this is what we do out of the ER. And she just very sternly looked across her desk at us and said, I'm totally all in. I'm so supportive of this. I've been waiting for somebody to do this, and I'm going to recommend or require ED-MAT for a lot of the patients that would qualify, so that we can keep them out of jail and keep them out of the justice system. And that was a huge eye opener for me. That was a day when I was like, wow, what we are doing is so much bigger than medicine. It's so much bigger than emergency rooms. It's really changing people's lives, and the community really values the work that we're doing. So to me, that was a really key conversation very early on in our Bridge program. And I just really thank, you know, the Bridge program for even facilitating that, because I would have never had that conversation if I hadn't gotten involved from that perspective. But ever since then, you know, I've always just had this larger perspective about the work that we're doing. And, you know, we look at harm reduction groups, community partners, even faith-based organizations and schools. I mean, these are all potential partners that can be your allies and your advocates. You just have to be ready to talk to them. And really, I don't even know where I picked this up, probably from, you know, a TED talk or something, but just remember the power of saying yes and then actually, you know, talking about what your goals are. And if you just do that over and over again, you're going to be able to find common goals, even with people that you have nothing in common with. And you'll be able to figure out some way that you can work together, whether that's law enforcement, the justice system, you know, different civic organizations, et cetera, that you would otherwise like never check into. You'll be surprised by how many, you know, this is a problem that just cuts across so many social barriers and so many different other boundaries that society has, that you will find a lot of common partners in places that you never would have expected. Next slide. Go ahead, Aimee.
Oh, thank you. And I just wanted to say, you know, some of the pictures from that slide were from my outpatient partners in Sacramento. And I've just been so amazed that once we opened up the doors and looked outside of our hospital to try and build outpatient partners and working with our federally qualified healthcare centers, it's really been amazing and eye-opening to me, in that we can really build on those relationships and really do a much better job of taking care of patients when we have those closer connections with our outpatient partners. So it's really about opening your doors. Speaking of which, this is outside my doors. This is actually one of the encampments that we have here in Sacramento. And frequently, one of the things that is talked about is treatment resistance in our people who are experiencing homelessness. And I did a review of the folks that we have seen at UC Davis and just pulled 300 patients to kind of look at them. And over 3/4, 75% were covered by Medi-Cal, and almost half reported they were experiencing homelessness, and about a third had a comorbid psychiatric diagnosis. And this is the patient population that we're able to get into treatment. And so this concept that people don't want treatment, I think, is simply not true. And what we are learning is if we make it easy for that person to get into care, they do want it. And actually, when we looked at it, the people who were experiencing homelessness had higher rates of connecting to treatment, an odds ratio of about 2.3 versus people who were not experiencing homelessness. And that was statistically significant. So this was actually a positive indicator of someone who we were able to connect into treatment from the emergency department. And I just think that that is remarkable. So when you see someone that would traditionally be thought of as treatment resistant, that is not a function, that is actually someone who is probably more likely to follow up if you make it work for them. Next slide. And for those of you who don't know, Rais has a second hat as a public health officer. So I'm going to let him kind of talk a little bit about how this work really relates to public health.
Yeah, thank you so much. So I have the privilege and some days the misfortune of being the interim health officer for the county as we kind of navigate this new era of the pandemic. But before the pandemic hit, they actually had approached me just to say, hey, can you help out? It sounds like you're meeting a lot of people and making a lot of inroads with your MAT program. And we really just, respect that you're trying to bridge just a lot of things that need to be bridged, but no one has thought of this before. And again, this diagram is something that I made just for this lecture, but this is something that I think really applies to what California Bridge Program has been doing all this time. And I think will apply to all of you, no matter which county that you're living in, which is that, the mission of public health is to go upstream. And the more that I learn about public health, the more it seems true that they really do want to invest in harm reduction programs, whether that's related to perinatal health and maternal outcomes, or sexually transmitted infections and HIV and hepatitis C, or obviously substance use. Public health always just wants to prevent problems before they happen. At the same time, behavioral health obviously has a huge interest in substance use disorders and taking good care of those patients and making sure that their goals align with those of public health. And then the California Bridge Program, I think all of you on this call are most likely affiliated with clinics and hospitals and emergency departments. So you sort of see the instant need and attraction for doing work related to substance use disorders and really helping those patients get on the road to recovery, just because we want to prevent complications. We want to be good stewards of our hospital resources. And we really do want to, take the whole care of the patient, not just for the acute visit, but for really the rest of their recovery. Well, it turns out that, the work that we're doing with California Bridge is really overlapping all of those missions. And the reason that I think that that's important for this discussion is that not a lot of people recognize that this might be a good pathway for sustainability. So I know that many of you on this call are wondering, what's going to happen when the BHPP program ends, or what's going to happen for the next funding cycle, et cetera. Think about, reaching out to public health and think about reaching out to behavioral health in your county and have this conversation. Obviously, you're going to have a lot of documentation because you're collecting really good information month after month and week after week with every encounter. But you can then go to them and say, look, this is the work that I've been doing for preventing complications. This is the work that I've been doing to help my patients go upstream and really avoid all of these bad outcomes that are happening to patients as a result of the drug epidemic. And I think you'll find some very sympathetic ears. And so just keep that in mind, that connecting with public health, it may be worth your time. And I'm more than happy to, talk about specifics if anyone's interested. We'll share our emails at the end of this talk. But just, something that, again, didn't occur to me till very late in the game, but something that I think is worth sharing once you start figuring out how to expand your program and really trying to make it more sustainable.
And speaking of sustainability, we'll go on to the next slide. I forgot. This is about documentation. So 2 pieces. You want to make your program sustainable in 2 ways. One is make it really easy for the clinicians to do the right thing. Dot phrases that you can use for your MAT. pathways in EPICS and EMR that really kind of leverage the EHR for good, not for evil, to help make it easy for the clinicians to do the right thing. Embed a COWS calculator in the EMR. I have one in EPIC. And really posters and signs with contact information so people know how to make this part of their regular workflow. Next slide. And then the other key piece for sustainability is really we have to have this work that is supported. There has to be support for this really important work that you are doing. Unfortunately, we're working on that, but also we have had some early victories. The ED-MAT code, this one that you see here in the left-hand side, G2213, is live now. So this is billable by Medicare. So CMS created this code, started January 2021, and in recognition of all the amazing work that you have done, DHCS approved this. So this is covered by Medi-Cal as well. And they did that in recognition that you guys are doing this amazing work, saving lives and getting people into treatment. And so what this does is this is a procedure code. So is it an extra billing code in addition to the level of service code, the E&M code that you're billing, that encompasses all of the steps that you are doing, kind of the identification, the initiation of MAT, the referral to ongoing care, and arranging supportive services. And that is encompassed in this code. And you can bill this right now, Medicare and Medi-Cal. So use it. The other things that we're looking at is there are special expert codes. Expert for drug and alcohol is required covered service in the outpatient setting. And we think it should be covered in the emergency department too. This is where the patients are. We can take advantage of that moment. So this is something that we are looking at, these two codes around screening, brief intervention, and referral to treatment to apply those to the emergency department. They are not required to be covered, but they could be. So you could work with your payers to cover these codes in the emergency department because we think it's going to make a huge difference in patients' lives. Next slide. Okay, so I know we're a little bit over where we wanted to be, but we want to hear from you. What are your barriers? Does this seem feasible? I know we're asking a lot, but this is really key in really saving lives and addressing this epidemic. We really have to all come together because we've been digging this hole for ourselves. So we want to answer your questions. I did see one question early on, which I tried to answer in the Q&A, but I think we all have it. And that is engaging the C-suite, because I think there's this common perception that people do not want people who use drugs, or this concept of having addicts in the hospital. And I had this conversation really early on with one of the administrators in my hospital. And he said, you don't want to make this a drug addict center of excellence. And I said to him, well, we already are. I mean, have you not been in the emergency department? Do you not know that the patient population that we serve? So for anyone who says, I don't want people who use drugs in the hospital, one, that is wrong and stigmatizing. But two, that is the population that we serve. We are just not doing a good job of it. And we can do better. And to tell them, like, by treating patients, we can actually increase people's engagement in outpatient treatment. We can decrease those readmissions. So this is the population that we're serving. We just need to do a better job. And second, we took his brilliant idea, and there is now the Cal Hospital Compare Opioid Honor Roll, which really awards hospitals for engaging in this work. And so we created an award for the C-suite so that they can have some positive reinforcement for doing the right thing. So those are my two strategies for engaging the C-suite. And happy to answer any other questions. We'd love to hear from you.
Just to, oh, go ahead.
From Camilla at Santa Barbara, who's our great physician champion at Santa Barbara Cottage. Camilla says, here at Santa Barbara, we're incorporating the new billing code for OUD. She's curious if maybe there will be some other codes that might eventually be developed for other substance use disorder treatment.
So correct. The procedure code is specific for OUD and initiation of medications. And this is where I think, like, we know that opioids are not the only problem out there. We have alcohol, we have stimulants. And so this is why I think pushing really hard to have that SBIRT code, the screening, brief intervention, referral to treatment, apply to the emergency department, because this is where we're encountering people. So that's something that we're working really hard on.
And I would add, just keep track of all of the non-opioid substance use disorders that you're taking care of. I mean, you're going to be seeing them. People are going to call you about people with mixed substance use disorders, alcoholism, methamphetamines. My feeling is all of that will be coming down the line as well, and that this is one that is available now, but definitely keep track of the other patients as well, because you never know when other billing codes, et cetera, will come down the line.
We have another question from Nicole Wojtal, who's our champion at Antelope Valley. And I think
Hi, Nicole.
Hired a son. I think this son into our son trainings. And I believe Nicole was Race's resident or something of that order. So Nicole asks, how do you get homeless patients to actually follow up at an outpatient MAC clinic? Most of the time, these patients do not have phones or transportation. It's an act of God at our hospital to get a bed at a shelter.
Yeah, it's hard. This is another, I think, piece that public health really can help with, because they actually have gotten a lot of resources for homeless patients as a result of the pandemic, and that they may actually be able to leverage some of those to provide shelter, maybe even help with things like transportation and a mobile phone. Those are some of the things that we've been able to track down here in Fresno. Again, there's a lot of local resources that once you start asking around, I think it may be available, that may not be coming through your hospital, but may be available through like community-based organizations or other civic organizations that, they all care about the same issue, which is, the homeless population is, that's just a whole other epidemic that's on top of the substance use epidemic. But, I think being creative, and if you can't get the answers within your own hospital, that's where having a substance use navigator that can really track down some of these resources has been just a lifesaver for us here in Fresno. Thank you to Chaya Vang. And I think that other substance use navigators, once they start to get established in your organizations, they will quickly be able to find those kinds of resources that, again, may not be available formally through the hospital, but certainly the patients, once they leave the hospital, can access those kinds of resources in community settings.
Yeah, and I just want to put a plug in for our substance use navigator trainings and the mentors who we have available. So sons getting started in their role, or really anyone who wants to increase the navigation abilities for patients who are experiencing homelessness, we will embrace you and give you all the ideas and resources that we've ever seen. So please never hesitate to be in touch with us about accessing our son resources. A couple other questions coming through the Q&A. So Leslie Dixon asks, hypothetical but curious from a pharmacist, is Sublocade an option in the ED for initiation? I know it's not labeled that way, but if we have concerns about high death rates in the first weeks after an ED visit, does the benefit outweigh the risk? Is this being studied by your team? Is reimbursement an issue?
Yes.
Wow. Oh, go ahead. Thank you, Aimee.
I'll let you answer that.
Yeah, go for it.
So Sublocade, fantastic question, would be amazing in the ED. I know that Highland is using Sublocade through the emergency department, but reimbursement is a challenge. It's also something that's challenging to get onto hospital formulary because it's been approved for outpatient, not inpatient use. But I think it is a really fantastic potential option. There's also currently a NIDA trial around Sublocade for opioid use disorder. So I think that answer is coming. But I think that it is promising. I love the concept of these injectables because it just makes life easier for the patient. And I think once we get the data from that NIDA trial, we'll be in a better position to argue for coverage for Sublocade from the emergency department. So more to come. You guys are cutting edge. And so I think that's part of what is so exciting about this work is you're really thinking about ways to take care of patients and really kind of pushing the envelope of where we need to go.
Yeah, and I actually want to add on to answering Leslie's question and also answer Nicole Castaneda's question at the same time, which is what advice do you have for a small rural hospital with limited resources We are currently in the process of hiring a son through Vituity. That's great. We're so excited you're able to utilize the Vituity agreement to hire your son. So my advice for you is, first of all, as soon as that son is hired, like before they even start, if they're open to engage before their start date, to loop them in with our Son Mentor network. I'm not exactly sure who your son mentor is, but you can be in touch with me and I can get you that information. And the other thing I want to say is to really utilize these trainings. These trainings are recorded and available. And Nicole, I would encourage you to go backwards in time to our YouTube channel and watch our last training, which was Josh Luftig and Ariana Sampson talking about integrating sons into hospitals. Might be really interesting for you as you're about to hire your son. And for Leslie, we actually have Andrew Herring on tap to deliver one of these trainings about injectables specifically, I believe in July or June. It's on our website, bridgetreatment.org/training. So you can register for that today. And I know it's a couple weeks away, but Andrew is really at the forefront of testing these new ways of delivering this medication. And he's going to talk about it in exactly this format in a couple of weeks, really. It sounds far away, but it's almost April for anybody looking at a calendar. So why don't we talk about success for a little bit, and then we'll make sure everybody knows what's coming up.
Okay, this is the part where this risks becoming a TED Talk, but we're trying not to make it so. What I wanted to do is just share some very basic bedrock kind of fence posts that I think if you can commit these to memory and commit them, to almost becoming mantras, that I think they will serve you really well in every conversation. And I think that part of the reason that I like to do this is just my approach is like, I don't like to go to people with problems. I like to go to them with solutions. And so this basically is just a bunch of different solutions that I think if you can just find the right people and the right audience, that this will actually rapidly expand your MAT services at your organization. So what does success look like? We're going to ask this question and answer it in several different ways. So I think first and foremost, a success looks like an emergency department, next slide, that says addiction is not a moral failing and that it's a chronic disease. And you will be surprised how many different ways people say this, and yet it still slips through, and then people still find ways to stigmatize and judge those who struggle with substance use. So we just have to keep reminding ourselves over and over and over again that we're not dealing with a moral failing issue. We're dealing with a chronic disease, and that we need to really empower all of the clinicians and staff in our organizations to just take it on as a chronic disease and really start solving it as within that lens.
This, I think, is the key feature. That's the hard part, is understanding that addiction is a chronic illness. But really, that is the key to the change that we're trying to make. And whenever someone is designing a system of care for an individual with a use disorder, you take a moment and pause and say, would I design the same system for someone with COPD, with diabetes? Like, would I design the same system for them? And if the answer is no, then you're doing the wrong thing. And so this is really just the key piece that really drives all of the change that we're trying to see.
Yeah, and what I've started to teach my residents is that, opioid withdrawal at the level of the brain really acts like seizures. And if you just think about whenever someone's in opioid withdrawal, they're basically having a seizure, even though they're speaking plain English, they're making complete sentences. That's really what's going on at the neurochemical level. And so you have to stop the seizure. You just like we wouldn't judge someone and call them a moral failure for having a seizure disorder. The same thing applies for people with substance use disorders. And that, I think that gets a lot of mileage for people, especially in the emergency department setting. The next way that we'd like to answer this question is really just saying at the level of the hospital, again, this is very basic when we put it on paper, but people forget this, and we just have to keep reminding them, is that all people deserve rapid access to evidence-based treatment with dignity. It has to be rapid, it has to be evidence-based, and it has to be done with dignity. That's not too much to ask, even though it seems like this is just a giant lift from wherever you're standing, like, wow, how am I ever going to establish MAT? This is really what we're trying to do, and it shouldn't be that hard. Because this should be the standard of care for any disease, anytime, for any patient in the hospital. And that's all we're asking for with MAT. So again, if you commit this to memory, it'll just roll off your tongue, and then people will be like, well, of course I want to support that. Why would I not? It's really hard to oppose this, right? Even if you're have a totally different perspective about drug use, addiction, et cetera. It's hard not to agree with a statement that's this almost bland, but I think it does speak to where we're trying to go with this, which is, I think one of our mantras that one of our other regional directors likes to use is to say, let's make buprenorphine boring, And so whenever you see a slide like this, you're like, wow, that's a pretty boring statement. And that's kind of what we want to do with this, is we just want to make it as boring as high blood pressure and asthma and other chronic illnesses, to say, well, of course, all of those people deserve evidence-based treatment, and so do our patients that are struggling with drug addiction. Next slide. Do you want to talk about this one, Aimee?
Yeah, so this is really, what does success look like? And that is the blueprint. And so go on to the next slide. I'm really excited about this. So this is our blueprint. Quick plug, we put together a comprehensive blueprint for the treatment of opioid use disorder in the hospital with this fancy QR code. So you can just scan this QR code and have rapid access to our blueprint. And so I just wanted to put a quick plug for the California Bridge blueprint. All of the information, everything you need to know is in this blueprint. Next slide.
Yeah.
And then this is really the other question, and this is system-wide. Like, what does success look like? And the answer to that is you guys, is everyone on this call engaging in this work, and this amazing network of amazing rock star sites that just keep learning and growing. Next slide. And this is amazing. Go ahead to the next slide. This is this map of folks that we're engaging with. This is you on this call, attending this training, changing the way that the system works in your hospital, in your community, doing outreach to your community partners, talking to the folks at the hospital that's also in your community. And this is the way that we're going to win this war against overdose, is by coming together and engaging in this work. So the answer of success is really you.
Yeah, and sharing this map with your stakeholders is very powerful, because then they realize that they're part of a movement. And then of course they want, because of FOMO, they don't want to miss out. And so this just kind of breeds its own, I think, momentum. And then the next slide is, this is just something that I think all of us on this call are passionate about, and something that, again, is not something that we meant to, we didn't, I don't think, design our program to be like a social justice issue, but it seems like it has become one. And so whenever you talk about evidence-based approaches anywhere and everywhere, you're really getting into, wow, this is the best way to treat people and avoid a lot of the other outcomes that could otherwise happen to them, especially when it comes to things like criminalization of drugs. Next slide.
Yeah, so this goes back to when we talk about how we would design a system. And would I design a system that incarcerated people with diabetes who did not use their insulin? Would I design a system that incarcerated people who had COPD and continued to smoke? And the answer to that is no. And then you think to yourself, but the system we have incarcerates people who continue to use drugs and who are struggling from their illness. And to start to think that that is not the system that we would design. And the other piece that I want to think about with this is to recognize that this compounds the harms of substance use disorders, this criminalization of drug use, and to kind of think about that as the experience that many of our patients are coming to us with. And so there's that stigma of the way society views individuals who use drugs, and they're bringing that with them when you're trying to engage them in treatment. And so really recognizing that is the system that we have and that our patients are encountering, and to really work extra hard to overcome the stigma that they have even towards their own use. Next slide. And so this is the final question, is what does success look like? And that is a happy, whole human being. And that is a person who is able to rebuild their life and their relationships. Next slide. And this is, something that we all kind of think about success differently, and this just really kind of drives it home for me. For those of you know, this is Tommy Trevino, who has really taught me so much about substance use disorder, and I learn from him every day with the way that he is able to connect with people and to support them in their journey to recovery. That he really does such an amazing job. And this is just one of the text messages between a patient and a son that is grateful because they were treated like a person and given that open door of accessing treatment. And so just kind of leave you with that. Next slide. And so the learning keeps on going. Want to thank you so much for participating with us, for being on this journey, and kind of plug our next in this series, the Changemaker series, with our wonderful colleagues, Jen Zahn and BC, who are going to be digging into this concept of stigma, equity, and trauma-informed care. Really, I think a fantastic talk with some wonderful speakers, and we hope that you will join us. And we've heard you, many of you out there have responded saying we need more education for nurses because we recognize the amazing role that nurses play on the front line, and that they can really be the drivers of change in our departments, in our hospitals. And so we are launching innovations in nursing to really kind of help our nursing colleagues to be the drivers of change. And a quick plug for this March 16th at 10 o'clock. Hopefully you guys can register for that and share it with your colleagues. Next slide. And this is another plug with the fancy QR code. I feel like we're so tech savvy here at California Bridge about our Innovations in Nursing series. One is coming up just next week, and then the next Tuesday's in May. So please join us for that, those two talks.
Aimee, we just got a question that I want to highlight. I love this question. Do you have any classes specific to pediatrics and teens?
Oh,
what do you have to say about that?
Oh my gosh, so much that I can't answer in 3 minutes. I think that this is something that I'm really passionate about, and that this is something that we're going to really dig in on the next year. We are working with the youth opioid response, and we're going to try and build some partnerships and some protocols to do a better job of reaching our adolescents and young adults. Because, think about going upstream. This is where we can really make a difference and really start to change lives if we can reach this patient population. So more to come on this, but yes, super important and fantastic topic. I could spend a whole extra webinar on it.
Yes, so please keep putting the questions in the chat. We'll answer them. I think we have a few more minutes. To Natalie Thorpe asking for resources for pregnant moms. So Natalie, I'm not sure exactly what hospital you're from, but if you go to our resource page, which is cabridge.org/resource, we have materials specific to treating pregnant patients. So you literally can go to that resource page and just type in PREG and they'll all come up. And then our clinicians are available to provide any individual coaching you need to talk to providers about treating pregnant women. We believe strongly that pregnant women should have the same access to MAT treatment as everybody else who needs it. So go ahead and take a look at that resource page. What other questions do people out there have? And yes, Tammy, I echo what Aimee said. We are so excited to, we recently received some funding to really grow our understanding of youth treatment. And we're so excited to be able to say more about that topic.
Really quick though, we could plug our partners for young people in recovery, which is a really fantastic organization that we're going to be partnering with to develop tighter connections and better resources for our adolescent population. But right now you can look at the young people in recovery and see if they have a local chapter. They're a fantastic resource that is very peer driven and provide peer support to young people. So I would encourage you to check out that chapter. And just to let you know, yes, absolutely. And this is something that we're really focused on in the future. So probably future talk for a Changemaker series, huh, Elizabeth?
I think so. So for those of you who are looking for CME for this session or want to give an evaluation, go ahead and fill out this form if you don't mind taking a few minutes. It'll also be shared in the post-event email. So that is, this session was eligible for CME for clinicians and self-reported for other licenses. So take a look at that form, and we're happy to stay on and answer a few more questions. Great. Thanks, everyone. Thanks, Aimee.
Thank you.